Welcome back. Chapter 4 is titled Evolving Understandings of Health, and it does exactly what the title says. It traces how our field's definition of health itself has shifted from a narrow, biomedical, disease absence model toward a whole person, relational, and socially constructed understanding of health. This chapter builds directly on Chapter 3. Last time we asked who health systems serve and whether that's just. Today we ask a companion question. What do we even mean by health? And how does that meaning get produced? Through the patient-provider relationship, through interprofessional teams, and through the broader social and physical environment a person lives in. For our nursing and health sciences students, this chapter will connect directly to clinical practice models you're already learning. Patient-centered care, integrative medicine, interprofessional collaboration. For my communication students, pay close attention to how communication itself is treated not as a tool added on to care, but as the very process that constructs what health means for a given patient. Today's overview has 8 interlocking pieces, and I'll group them into 4 clusters as we go so they're easier to hold on to. Cluster 1: Patient-provider relationship. Patient-centered care, integrative healthcare approaches, and the therapeutic relationship, including provider self-fulfillment and graduate medical education. Cluster 2: Meanings of health, and how integrative medicine and CAM, which is complementary and alternative medicine, fit within a whole person healthcare social justice approach. Cluster 3: Systems and context, interprofessional communication and coordination of care, and the collaborative principles within the ecological model of health. Cluster 4: The socially constructed and economic dimensions. Clinician-patient communication as socially constructed and the value-based approach to integrated medical and social care. By the end of this lecture, you should be able to move fluidly between these 4 clusters. They're not separate topics, they're 4 facets of the same evolving object, which is what we mean by health and care. So let's unpack these clusters and the different topics that we'll discuss under them. Patient-centered care. This is a section title slide, so let's use it to set up the frame. Patient-centered care, or PCC, is often used loosely in healthcare settings. It's almost patched around as a marketing phrase. In this chapter, we're going to define it with precision and root it specifically within the whole person healthcare framework introduced in this book. Let's start with an example. This slide is titled Athletic Trainers Viewing Their Patients Holistically, and the image shows an athletic trainer treating her patient on a basketball field. Before we define patient-centered care abstractly, let's ground it in a real example from an unexpected setting: athletic training. You also have this URL that's embedded in this image, copy pasted for you on the slide. It's a little unwieldy, but if you look under the lecture slides on my classes, you'll see this under the label link on slide 4. Athletic trainers viewing their patients holistically. So you can click on that link and browse along. So please pause here and read the George Mason University feature on how whole person care improves student athlete outcomes. The link itself is titled, Why It's Important for Athletic Trainers to View Their Patients Holistically. And it's from their College of Education and Human Development. As you read, think about these 2 questions. First, what elements of whole person healthcare can you identify in how these athletic trainers describe their approach? And second, how does the article define patient-centered care in this context? Does it just look at the physical injury care alone, or does it look at something broader? Let's now formalize patient-centered care within WPHC, or whole person healthcare, across 4 dimensions. WPHC's emphasis on patient-centered care itself. It brings together a diverse range of healthcare resources to understand the needs of the individual patient, considering physical, behavioral, emotional, and social services together. Not separately and sequentially, but as one integrated picture. Second, WPHC's emphasis on diversity, attending to the individual needs and background of each patient, and specifically addressing the disparate risk factors facing disadvantaged, minority, and marginalized patients. Notice that this connects directly back to the social justice lens from Chapter 3. The third point is on WPHC as centering humanistic approaches in provider well-being. Here, providers are asked to acknowledge their own humanity within the healthcare relationship and to cultivate critical self-awareness of their own self-beliefs, thoughts, and feelings as they interact with patients. This suggests that care isn't a one-directional act performed on a patient by a neutral, objective technician. Actually, the provider's own humanity is part of this equation of care. That's a solid shift. Fourth, WPHC and meanings of health. This centers the psychosocial, communicative, historical, and environmental contexts, and it asks how patients themselves feel about their disease and their health as a genuine condition of their clinical care, not just what a lab value or diagnosis says. So now let's look at patient-centered care in meanings of health. In this slide, we have 3 competing definitions of health itself. And I'd like you to pay attention to how each one implies a different model of care. The first is health as the absence of disease. If you recall, this is the classic biomedical definition. It's concise and it's definitely measurable, but it's very narrow and doesn't really capture the spirit of health. Second, Health as a state that allows the individual to cope with all the demands of daily life. How about this? It is definitely broader, but notice that it still assumes that health means the absence of disease or impairment. It merely adds a functional criterion on top. So now we have the third one. Health as a balance or equilibrium that an individual has established within themselves and with their social and physical environment. This one, if you notice, is the most expansive definition. And why is that? It allows someone to be living with a disease or impairment and still be considered healthy, as long as they've achieved balance or they believe they have balance and can live a quality of life by their own choice. Now, this third definition is the one that WPHC is built around. And it's a meaningful departure from where we began, which is that health is the absence of disease. It shifts the locus of authority over what counts as healthy from the clinician's chart to the patient's own lived experience and meaning making of balance and choice. I'll let you think about that for a minute. So now, that third definition, which was health as balance or equilibrium, does a lot of conceptual work. It asks how patients themselves feel about their own health, and it deliberately combines the biomedical with patient-centered care and the clinical with the humanistic. So the result of all this is an empowered patient, someone who's a genuine participant in the definition of their own health status, not just the recipient of a diagnosis. So in this case, the patient is not a passive receptacle receiving a diagnosis from an expert physician or provider. This definition also foregrounds environment in a very specific way. It includes relationships, friends and family, social context, which is media, politics, economics, and community, and legal context, laws, policies, and executive orders. Health, in other words, is never just inside the body. It's produced in relationship to all these surrounding systems. So now, let's move from defining health broadly and deeply to a specific clinical model that operationalizes this broader definition, which is integrative medicine, or IM. Let's warm up to integrative medicine with a concrete, evidence-based example most students find immediately relatable. Therapy dogs on college campuses. You might have seen them at SU too during final break time. So this link in this image is provided on the slide. It's embedded in the image, which will be hard to access from the video. And you can see the URL on this slide, but that's a complicated URL. So what you can also do is on my classes, under this video link is the link for slide 9. And you can click on the link for therapy, dogs, and stress on that page on my classes. And this image shows a man with a therapy dog, and the man is sitting in a wheelchair. So pause and read this news coverage on this article. The article in this link is titled Therapy Dogs Provide Mental Health Benefits for College Students. College freshmen actually. Now, I'm sure you can relate to that. As you read, ask yourself, what key findings stood out to you most? Was it the specific mental health outcome? The emphasis on repeated versus one-time exposure, or something about how researchers measured well-being over time? Now let's define integrative medicine formally. IM nurtures balance between body, mind, and spirit, using evidence-based conventional treatments alongside complementary treatments and services. You'll notice two things immediately. First, it is holistic and individualized, and it is oriented towards prevention and health promotion, not only treatment after the fact. Within WPHC, IM, or integrative medicine, specifically integrates complementary and alternative medicine, or CAM. What is CAM? Think about acupuncture, mindfulness-based stress reduction, or therapy animals like we just discussed in the previous slide. All of these fall under complementary and alternative medicine approaches. This approach is explicitly multidimensional and integrated. And this is important for combating misconceptions. It remains grounded in scientific inquiry. So, integrative medicine is not anything goes. It is the deliberate integration of complementary approaches that have an evidence base alongside conventional medicine. Now, IM also centers the therapeutic relationship itself as a site of care. This is a direct echo of what we said about WPHC and provider well-being. It's a collaborative approach to the provider-patient relationship, where the provider's own attitudes, values, and beliefs are a part of the relationship, and the provider approaches the patient's values, beliefs, and unique personhood with compassion. This emphasizes what the chapter calls the relational domain of treatment and care, attending to the complex, multi-layered nature of illness, not just its clinical presentation. It centers the patient-centered care by being respectful of the patient and responsive to their preferences, needs, and values, which include storytelling, centering the patient's life journey, shared decision-making, and even using metaphors to help connect with what's stigmatized or unfamiliar for the patient. Some of this we had discussed in the last lecture. For our communication students, notice how much of IM's definition is, at its core, a communication theory. Storytelling, metaphor, shared meaning making are all communication constructs. IM cannot function without deliberate communicative practice. For our communication students, notice how much of IM's definition is at its a communication theory. So now, given that communication is so central to IM, let's define the specific communicative task at hand. effectively communicating information about IM treatments, therapies, and approaches to patients, ensuring they understand the potential benefits and risks, how these practices integrate with conventional medicine, while also addressing their concerns and promoting informed decision making about their overall health and well being. Why is this important? This matters because it requires explaining complex concepts clearly, addressing misconceptions, and there are many misconceptions about CAM specifically, and providing evidence based information rather than anecdote alone. The specific health communication strategies at play include detailed explanation of therapies, clear, unbiased discussion of potential side effects and interactions, including interactions between complementary and conventional treatments, tailoring between communication style and information delivery to the patient's health literacy level and cultural background, and utilizing visual aids and educational materials to support understanding. So that's a lot of communication foundation in integrative medicine. In fact, what does effective communication about IM actually accomplish? That might be something you might want to know. So, this has 3 concrete outcomes. A, it empowers patients to actively participate in their healthcare decisions regarding IM options. It builds trust, both between provider and patient, and in the IM approach itself, and it optimizes treatments outcomes by improving adherence to integrative medicine plans. For our nursing students, this is something you should maybe dwell a little bit on, which is adherence isn't just about a patient's willpower or motivation. Adherence is, in large part, a communication outcome determined by whether a provider explained a complementary therapy clearly enough and built enough trust for a patient to actually follow through. For my communication students, it's part of what you can be involved in translating materials, creating branding, contexts, and serving as a patient advocate. So now we're on to interprofessional communication. We've talked about the provider-patient relationship in depth. So let's zoom out to the team and system level, which is interprofessional communication, or IPC. Achieving the goals of integrative medicine care requires coordinating across different systems of care, but this coordination faces real, well-documented barriers. First is knowledge gaps. Most doctors, nurses, and pharmacists in the oncology domain, for example, lack appropriate knowledge to inform evidence-based CAM use with their patients. Second, media framing. News media often frames CAM negatively as lucrative, unethical, and lacking a solid evidence base, which shapes both public and provider attitudes. Third, system-level cost barriers. Addressing CAM programs and centers increases hospital costs, and much of this care remains non-reimbursable by your insurance, creating a structural disincentive for institutions. Then there are the training gaps. There's a lack of clinician training in the ideologies and practices of CAM integration, and a lack of provider knowledge of specific integrative medicine modalities and how to implement them. This remains one of the central challenges to interprofessional coordination. Finally, there is the issue of health literacy. Patients' own health literacy also affects acceptance of CAM modalities, which in turn shapes whether providers feel it's worth the communicative effort to introduce these options. If you think about it, notice how every one of these barriers is fundamentally a communication and information issue. It involves training, media narratives, and health literacy. So even though some of them might look like financial or structural barriers, they're fundamentally a communication concern. Now let's look out even further, one level further. From interprofessional teams to the full ecological context surrounding a person's health. And let's take a look at the ecological models of health. Ecological models focus on the relationship between individuals and their context. Specifically, the interdependence between individuals and their environment, which requires approaches that are complex and multi-level, not single cause. So we are not looking for simple answers. Ecological models were developed specifically to address the limitations of individual behavior change models. What are these limitations? Behavior change models tend to place the entire onus on the individual. They tend to be purely objective and quantitative in how they understand health and disease. And they tend to view health through a lens of deficits, which means things like, what's wrong with this person, rather than through a lens of capacity or context. Now, what do ecological models do differently? Ecological models instead emphasize the dynamic nature of health as an ongoing process, characterized by complexity, interdependence, and adaptation. So health is not a fixed state to be measured once. In fact, ecological models add 3 additional features to the relationship between individuals and context, which is the social construction of knowledge. What does that mean? Meaning, what counts as known about health is produced through social processes, not simply discovered. It's produced through collaboration, and it's produced through attention to social processes and social settings as active ingredients in health, not passive backdrops. So now, this chapter has identified 10 interlocking principles describing the relationship between individuals and their context. So if we group them among related concepts, here's how they'll look like. First is shared and mutual understanding, which is how people use resources and negotiate constraints at the personal, individual, and community levels. Then we have shared norms guiding the use of resources and responses to constraints. Then we have the role of social settings in co-creating shared meanings and experiences. Next, we have how people behave and adapt their behavior based on situations and time. Next, we have reciprocity in relationships. And then we have external settings, norms, and structures. After that, we have interdependence and relationships. And finally, we have social processes. Now you can apply this. Take a minute to maybe check it out for yourself. Under the lecture slides on my classes, there is a link for slide 19 titled Fairmont State University Healthy Campus Initiative Psychological Health. Take a look at it and see what do you think about the ecological model perspective as we've discussed thus far, based on how Fairmont University, actually it's Fairmont State University, applies it for their Healthy Campus Initiative. You might see some interesting connections. Do you think there's a principle that's missing or underdeveloped in this example? Which of the 10 principles that we are discussing here show up most clearly in how the initiative is designed? Now, from the perspective of ecological models of health, let's focus on the environment, because this is the piece practitioners most directly designed for. This involves community level resources, which means everyone's context should make it easy to have a healthy lifestyle, supported by policy design that encourages healthful choices, not just individual willpower to resist the bad choices. Mutual construction of collaboration and trust. This includes the social and historical context, how participants view their own context, and how participants actually use resources and navigate constraints from their own vantage point, not from the point of how the institution makes assumptions about them. And then it requires a collaborative approach, which involves shared creation of solutions, shared creation of meaning, and building trust as an ongoing process. And then it involves, finally, community-based participatory research. My graduate students will find this term very interesting, and maybe they've come across it before, but it is something definitely that they should be cued into and maybe engage in practice. This involves being attentive to community knowledge and treating the community as an equal participant in designing solutions, not simply a study population. So what this last point, CBPR, is a direct methodological expression of that social justice sensibility we talked about in Chapter 3's lecture, which is engaged scholarship applied specifically to ecological models of health. Isn't that interesting? This is our final major section, which is how does everything that we've talked about thus far, patient-centered care, IM, interprofessional communication, and ecological models get operationalized at the level of health systems through integrated medical and social care and value-based approaches. So integrated medical and social care is defined as bringing together the inputs, delivery, management, and organization of services related to diagnosis, treatment, care, rehabilitation, and health promotion. This model exists to address real persistent challenges: fragmentation of patient services, poor coordination, and discontinuity of care. Successfully integrating care requires attention to financing, a shared vision across providers and organizations, and a clear target audience for the resulting services. Now, this chapter has offered 3 scenarios to help you imagine what integrated medical and social care communication actually looks like in practice. So, here are three prompts, scenario prompts for designing patient education materials. Just for you to think through. You will have separate prompts in your engagement and advocacy lab work. But this is the lecture component, and this is just for you to sort of consider. So here's the first scenario. A diabetic patient receiving nutrition counseling from a registered dietitian while also being connected to a community food pantry to ensure access to healthy food. So you're imagining what integrated medical and social care communication actually looks like in practice, and that's the first scenario. The second scenario is a person with a chronic mental illness getting support with housing stability through a social worker while attending therapy sessions. And the third scenario is a pregnant woman with limited transportation receiving assistance with prenatal appointments through a community health worker. This is what integrated medical and social care communication actually looks like. So these are the health outcomes that we see when we are looking at an integrated medical and social care communication picture. Notice what all three scenarios have in common. The medical intervention alone, in the first case it's nutrition counseling, in the second therapy, in the third prenatal care, are necessary, of course, but they're not sufficient. Each scenario requires a second social support layer, which could be food access, housing stability, transportation, braided together with the clinical care. So those are the social determinants of health. So now this sort of integration of clinical and the social determinants happens along two axes. And you want to think about the language we use here. It's precise, and whether you're in communication or nursing or health sciences, it's going to be important for your own future systems work. The first one is vertical integration, which is integration between different levels of care. For example, a single-site medical center with shared processes and electronic medical records, connecting primary and secondary care. Second, horizontal integration, which is integration between providers, organizations, networks, or groups within the healthcare system at the same level of care. So the advantages of this integrated approach include, you can see there, reduced fragmentation of healthcare providers, lower barriers to accessing care, increased efficiency, improved coordination and communication between care providers, avoidance of duplicated or contradictory clinical decisions, and shared accountability across the care team. Now let's connect these advantages back to patient-centered whole person health care specifically, and we can do that across three dimensions. First, access. Integrated care can be more accessible across geographical locations, especially for patients with varying economic means and insurance coverage. Second, coordination of care, which means this is team-based, involving providers within the same facility, such as the primary care physician, a specialist, a physician assistant, or a nurse. Or it could involve people across different facilities entirely. Third, technology and continuity of care, which involves integrating technology into diagnosis and treatment, such as during virtual healthcare, computer-assisted support, electronic health records, medication adherence apps, e-prescribing, and the option of online visits, such as patient visits conducted via webcam and telephone. So, for my nursing and health sciences students, this is likely the most operationally familiar section of the chapter. You're seeing right now the infrastructure behind terms like care coordination that you might hear a lot, and telehealth that you probably already use in clinical settings. Now let's start to close this chapter. And as we do so, let's look at the emergence of the value-based approach to care. That's gaining increased resonance across systems. This is a system-level response to everything we've discussed today. What all does this involve? First, organizing into integrated practice units, or IPUs, that provide the full cycle of care for a patient, addressing comorbidities, complexities, and other individual factors together, rather than treating each condition in isolation. Second, measuring costs and outcomes for each patient, which is a shift from measuring volume of services delivered to measuring value produced. So instead of measuring the volume of services delivered, we start to look at or measure what value have we produced. Third, moving towards bundled payments, which involves covering the full care cycle for acute conditions, the overall care for chronic conditions over a predetermined period, or primary and preventive care for a specific patient population, rather than paying piecemeal per service that makes such a huge difference when we do that. Next, integrating healthcare delivery across separate facilities. So we assign a single physician leader for each patient and adopt common protocols across sites. How much simpler does this make this for each patient? Next, geographically expanding healthcare providers' coverage, which involves linking these through satellite locations and affiliations with local community providers. And last, using healthcare information technology platforms that are patient-centered, versatile, and easy to navigate, making medical data accessible to all healthcare professionals involved in a patient's care. Those of you who are in Salisbury, not necessarily over summer right now, but at any point, you might look at Tidal Health's information technology platform and how it makes your care patient-centered, versatile, and easy to navigate. And how might it make your medical data accessible to all healthcare professionals, whether here or in another healthcare system. So step back and notice through the through line through this entire chapter, from the therapeutic relationship to interprofessional teams, to the ecological context, to system-level financing. Every layer of health we've discussed today is ultimately about redesigning systems and the communication between and within them, and around the whole person, rather than on a single diagnosis or transaction. So that is a lot of ground. Let's close this by bringing it back to you individually, just like we did at the end of the other earlier chapters. We've moved from defining health as balance and equilibrium through integrative medicine and CAM, or complementary and alternative medicine, through interprofessional and ecological models, to value-based integrated medical and social care. Before you move on to this week's lab, reading review, quiz, and the engagement and advocacy section of the lab, think through what might be some key takeaways from this chapter's lecture for you personally, and how might you engage these takeaways in your own community, whether that's a clinical setting, a campus organization, or a professional practice that you're moving toward. It could be that you're working as a social media influencer, or with a healthcare campaign, or with a non-profit agency that has its main domain in health. Now, as I wrap out of this, think back and see how you might be understanding patient-centered care within the whole person healthcare framework, and be able to think through the 4 dimensions we've covered in this chapter. See also how you might explain the difference between the biomedical definition of health, which is the absence of disease, and health as balance or equilibrium. Why do you think whole person healthcare favors balance and equilibrium? See that you're able to name the barriers to interprofessional communication and coordination around integrative medicine. And see that you can understand the difference between vertical integration and horizontal integration in healthcare systems. Finally, you should be able to describe the features of the value-based approach to care, such as integrated practice units, bundled payments, and others, and explain how it changes what gets measured in a patient's care. Having said this, thank you for going through the lecture today with me. As you go ahead and look at the engagement and advocacy lab sections, a lot of these concepts will get clearer as you apply them in real-world application contexts. Thank you.